Okay, so I'm going to talk a little bit about a project that I came over to London to work on called Staying Safe. And I'm working on this project with Tim Rhodes here at the London School of Hygiene and Tropical Medicine. And this project's a Hep C prevention project, but it's got a bit of a twist. It's a bit different in that we're looking at people who've managed to stay free from Hep C, who've been injecting for over 6 or 8 years. Now the reason for this is that it's what's called a positive deviance theory, and that we're looking for people who are the deviants, so to speak, and that people who've managed to remain free from Hep C in London are only about 25% of injectors, especially if they've been injecting for over 8 years. So we want to know what these people have been doing right. What have been the protective networks, structures, environments, practices that are helping them to avoid hepatitis C. And it's about learning from people who are injecting, learning from the experts, instead of sort of casting them as people that are always doing something wrong and it being about risk and, stuff like that. Tim and I have interviewed 38 people who've been injecting drugs for over 6 years, mainly in Brixton and Islington. And each participant was interviewed twice. So another thing that was interesting about this project is it wasn't just focused around hepatitis C or injecting behaviours or risk practices, but it was a life history project. So we're interviewing people about their lives and what was important to them in their lives. And in this way we completely took the focus off hepatitis C. And so we wanted to find out, get a broader picture of what was going on for people. So what I did was I did most of the interviews, and I go and interview a person first, and I talk a little bit about the method because it's sort of interesting. So I do a life history with somebody, and so I get out these 2 sheets of, say A3 paper like this, and I draw a line and I'd say, so tell me when you were born, and so you're born here, and then is here, and tell me about what was significant to you in your life. And so we'd go through, and in this way the participant was really involved. The process was made transparent. They could see what was happening, what we were talking about, and it was great because often they would refer back to it and they go, oh, this happened around here and this happened around here. Anyway, so after the first interview, which was just about their lives, what was important to them, I'd take away this scrappy thing with my scrappy notes on it and the transcript and go and make up a proper computer-generated timeline. And you'd have, where the person was living, stuff about their family, stuff about their school, their relationships, their drug use practices, their income generation practices, harm reduction stuff, and then incarceration and things like that. And it was great because you could see how things linked up through people's lives. But what was really good about doing this was the participants really liked it, and it was something personal, something tangible that I could give the participants to take away. And the reactions to the timelines are really interesting too. One of the main findings in this project has been that a lot of the things that helped people stay safe weren't necessarily motivated by harm reduction messages, they weren't related to harm reduction messages, they weren't necessarily related to trying to avoid bloodborne viruses such as hepatitis C or HIV. They're often around really pragmatic, day-to-day, short-term concerns. And it's by harnessing those that we can develop harm reduction interventions that are meaningful for people who inject drugs. So I'll give an example of one, and one of those is vein care. Now I'm an ex-user, and a lot of people who I interviewed they could tell that. They might see my track marks or the way I said something, and I wouldn't hide it from participants. And this often led them to showing me all their abscesses and rolling up their arms and their sleeves, and I was really struck by the amount of injecting relating damage by people in the UK. It's very different from the scene in Australia and New Zealand, which I was used to, where people are not transitioning to groin injecting as much. There's nowhere near as many abscesses, infections, amputations, things like that. There's a primary concern about how to find a vein, how to keep their veins going, how to avoid infections, how to avoid abscesses, how to avoid transitioning to groin injecting, and to avoid the harms that are associated with that, such as amputations. And they weren't receiving any help with it. You know, people didn't have anywhere to go to ask about this stuff. And this was really evident to me when doing these interviews. And I had one woman, for example, both interviews, without warning, she'd stand up and pull down her pants and she'd go, "Oh, I'm not a lessie or anything, but can you have a look and can you show me if I'm injecting in the right place?" So she'd pull down her pants and show me the holes in her groin and say, "Is this the right place?" Now, I was never a groin injector, and so I don't know, you know, but, you know, it was interesting because I didn't come in there saying I'm anyone with any sort of medical background. I'm not. You know, I'm just a social researcher who happens to be an ex-user. But people were constantly asking me, "Is this the best place to go? Where should I go?" So one guy said, you know, I went and asked and they said, transition to smoking, start smoking. And he was like, "For fuck's sake, I don't want to be smoking." You know, so when people go and ask about help finding veins, they get advice to stop injecting. You know, that's no good, you know, and it's also shaming as well. And people have also spoken of really shaming responses to abscesses and things like that. I was struck by the amount of people who are not going to get any help for really significant infections and abscesses, often lancing them and treating them themselves, which just leads to them spreading. And the scars and the damage I've seen has been horrific. So that brings me on to one of my motivations, one of the motivations I've found that have helped people stay safe, and it's around protecting that, you know, make or break of the injection experience. For an injector, your veins are your most important things. You want to keep them going for as long as possible. So we spoke to a lot of people who'd started injecting before they heard of HIV, before they've heard of hepatitis C. Now, people who'd been injecting for a long time, a lot of them said that they didn't share. They didn't like to share needles. And this wasn't just sort of like, you know, a socially acceptable response, I never share, because the reasons they gave me for not doing it were so interesting. And the reasons they gave me for not wanting to share is they didn't want to use a blunt needle. Right? A new needle was not conceived as a sterile needle. It was not conceived as a needle that's going to prevent getting diseases, but it was conceived as a new needle, as a sharp needle. It's going to help me get a hit as quickly as I can, and also it's going to prevent vein damage and help me hold on to those veins for as long as possible. Now, while this may have been people's initial motivations, it was a practice that stuck and a rationale that stuck for people. And even people who've been injecting more recently spoke of this as being a primary motivation. So I've got some quotes here just to sort of hammer the point home. So Jeff, for example, he says, I always use fresh needles each time, less blunt damage off it. I've always tried to do it. That was the reason. There's not another reason. And now, and also Leroy. So Leroy was a great guy. He'd been injecting for over 30 years. And he spoke to me, he'd remained hepatitis C free, and he spoke to me of a pivotal encounter he had with a drug and alcohol worker 3 decades ago. And he went into this drop-in clinic. And he says, I just couldn't share, because once I had a needle and I dropped it and it barbed, and oh my God, that hurt. It just ripped into my arm. So I went down to a guy at the drop-in and I told him, and he says, "No, mate, don't do that. Never use it. It used works, never." And I said, "Yeah." And he said, "Yeah, every time you do it, man, it just barbs with your skin. Sometimes it can be tough." So I said, "Yeah," and I stopped. So, you know, that's so interesting, isn't it? Compared to today, you'd never hear that sort of message. The message is, don't share works because you're going to get a disease. Down at Leroy's experience 30 years ago at that drop-in centre, the guy was like, "Man, don't use used works. It's going to hurt." So it's really significant that a lot of participants spoke in these terms, and they still spoke in these terms even in this day and age where harm reduction advice around not sharing is about preventing diseases. So Andy said to me, for example, he said, "I'm not going to use a needle more than once. Once it's punctured my skin twice, that pin is dead now because it's blunt. Therefore, I can't share anyone else's because it's blunt already." That was one of the reasons. That is the main reason. So Andy there talks in the past and the present tense. He says that was one of the reasons when he first started injecting, but that is the main reason. That is still the main reason why he doesn't share. And also, people are not reusing their own works. They're not wanting, because they're wanting to have sharp works to keep their veins going, they're not wanting to reuse their own. So one of Andy, I think it was Andy, one of his protective motivations, protective practices to stop himself reusing his own works was to bend his needle after he'd used it and throw it in the sharps bin, so then he couldn't dig it out and reuse it. But that actually is protective against hepatitis C, because a lot of people, when you reuse your own works can get mixed up in between. You can go into the sharps bin, think you're taking out yours, somebody else has put one in. So it's a way of it's preventative against hepatitis C, people not reusing their own works. And the main reason people aren't reusing their own works is because they don't want to cause any damage. So, having a blunt syringe can cause vein damage, which can cause difficult injecting situations. This is what harm reduction needs to grab a hold of, and this is a pragmatic motivation that's really meaningful to people. Now, a lot of people who I interviewed, they're very present focused. They're about what has to be done for the day, getting their score, avoiding the police, avoiding overdose, getting a bed for the night, doing what has to be done. Hepatitis C is this sort of nebulous thing that they don't really understand, or that they see a lot of people have got, they seem to be doing all right. It's also really difficult to avoid, and again, it might not affect them for 10 or 15 years. This is what people tell me, it's something in the future. So it's sort of difficult for them to conceptualise it as an immediate priority, whereas, maintaining their veins is an immediate priority, but this priority is actually helping a lot of people stay Hep C free, because they're being careful not to reuse their own works, they're being careful not to share needles, because they want to have a clean hit. So, Giles, who is a service user representative, he said to me, people would rather use clean works because they're sharp for a start, so they're not going to be blunt. But does the message get through? Because Hep C, so what? I'm not going to drop down dead tomorrow. So, again, this is really interesting. Giles speaks of the visibility and temporality of hepatitis C. He adds, hepatitis C is not something you just see at the moment. The distinction between the visible and the invisible, as well as short-term and long-term risk, reflects participants' conceptualisations of hepatitis C as something that's not of immediate priority. So, I think it's really important for us to think about this and think about how we can engage with what's important for people who are injecting to provide harm reduction initiatives that are responsive to their needs. And, pleasure and utility are part of these narratives. And pleasure seems to be this sort of white elephant in the room when it comes to harm reduction. There's this narratives of avoiding risk and avoiding disease and recovery and this and that. But, for many people inject drugs because it's a pleasurable experience. And they're wanting to hold on to that, maintaining that pleasure as much as they can. And ways to maintain that pleasure actually, we found, are protective for a lot of people as far as avoiding hepatitis C. Inadvertently protective, but important nonetheless. So, how to harness those messages. And maybe, a lot of people I've spoken to are very disillusioned with harm reduction services. They don't feel connected to their drug and alcohol workers. They don't feel like they're getting their needs met. They don't feel like they're getting their immediate concerns met, which are things to do with, infection control, around abscesses, about trying to get a vein, things like that. And also not having the pleasurable aspect of their drug use acknowledged, about it always being framed as a problem, as a deviance, as something that has to be moved on for or transitioned out of. That's going to make people less able to feel that they can come forward and express their problems, with injecting related infections, or, asking help about where to find a vein. It may be controversial, but I think it might be time for harm reduction initiatives to take a leaflet, for example, HIV messages aimed at men who have sex with men, who actively engage with notions of pleasure in their marketing, and think about, we could think about a lot of ways, but one way is to think about the social marketing of syringes with messages about the capacity for sterile, therefore sharp works to prolong venous access, minimise unsightly scarring and decrease the need for a transition to groin injecting. These messages have the potential to resonate with injectors who are jaded or confused by Hep C prevention messages and may provide a hook for which to provide other protective interventions. Because, of course, hepatitis C is not just prevented by not just sharing works. The thing is it's really easy to catch by sharing equipment and other things. And what I'm not saying that this is a simple answer, but all I'm saying is that there is a need to re-engage people. And a lot of people, it just all seems too hard, right? If you can get hepatitis C from a tiny little droplet of blood from anywhere, why even bother not sharing? For a lot of people it just seems too much. So maybe it just needs to be made a bit simpler. And by engaging people, by acknowledging the pleasure they get out of injecting and acknowledging the pragmatic needs that they need to attend to day by day, you can provide a hook to bring in other interventions and then increase awareness about not sharing equipment and other messages like that. So that's one of the findings from the Staying Safe project. And Tim and I have just published an article on it in Addiction, which you can find if you can just Google Magdalena Harris and injecting, a few things come up, and that might be among them. So thanks.